Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, I am Dr. Colin Crowe, Assistant Professor of Family and Community Medicine at Case Western Reserve University, a family medicine physician at Metro Health, and podcast lead for Cardio's Team Best Practices. Today, we're diving into a critical but often overlooked issue in healthcare: medication labeling and patient understanding. Would you believe that 1.5 million patients visit the emergency department each year due to adverse drug events, which include medication errors? Medication errors are a common safety and quality issue, not just because of how medications are taken or how effective they are, but because complicated or poorly understood labels can lead patients to being identified as non-adherent to their regimens. Patient medication labels must be clear and easy to understand. So with me today is Karen Komondor, a registered nurse, the founder and president of Health Literacy 360, and president of the United States Health Literacy Association, and Sarah Aldrich Renner, a clinical assistant professor at the University of Toledo College of Pharmacy and Pharmaceutical Sciences, a clinical ambulatory care pharmacist, and a member of Cardio's Team Best Practices. Welcome.
Thank you for having me.
Thank you. So glad to be here.
There are so many factors that contribute to patients correctly using medications. 2 key areas include adherence and health literacy. So Karen, can you share some background on health literacy and how it impacts health outcomes?
Absolutely. So first, when we talk about health literacy, people often assume it's just about reading level, but it's so much broader than that. At its core, literacy is really about having the skills you need to make sense of information, reading, writing, using numbers, asking questions, thinking things through. And when we apply that to health, it becomes about whether people can understand what we're telling them well enough to use it in their everyday lives. That's really what health literacy is all about.
Yeah, thank you. That's so helpful. So I understand there are a couple of layers to health literacy, both personal and organizational. Can you tell us a bit more about that?
Absolutely. Healthy People 2030 defines it in 2 main parts. To put simply, personal health literacy is what individuals can do, finding, understanding, and using health information to make decisions. And secondly, there's organizational health literacy, which is what we as health professionals, health systems, clinics, pharmacies can do to make that easier. When it comes to medication safety, organizational health literacy is critical. If the label is confusing, we're setting patients up for failure before they even open the bottle. We need to design labels that work for everyone.
Yeah, thank you, Karen. Communication is really key throughout our health institutions, just like you said, and throughout our patient interactions. So what about those patients who don't have literacy concerns?
Oh, great question, Colin. We used to try to figure out who had low literacy so we could tailor communication just for them. But honestly, anyone can misunderstand health information. So now we treat clear communication like universal precautions, the same way we treat hand washing. It's something we do with everyone, every time, because we can't always predict who needs extra support. Clear communication should be the standard to prevent any misunderstandings.
I remember universal precautions from our Teach Back episode, and I'm really glad we're bringing this back up. That helps set the stage for our discussion today surrounding medication labeling. Let's talk about the real-world impact of unclear medication labeling. Sarah, what's at stake?
Well, unclear labeling creates confusion, which increases the risk of adverse drug events, as well as poor control of conditions requiring that medication. Let's take an example. So a patient is prescribed glyburide, metformin, and atenolol. The medications are written with different dosing frequencies and styles. So for example, one says twice daily, the other says every 12 hours, and the third says morning and evening. There could also be a variation where one of them says take at 8 a.m. and 5 p.m. A study by Davis and colleagues looked at medication labels similar to what I just mentioned. So they looked at 359 patients and they interpreted 10 different instructions for those 3 different medications. Overall, they had around 3,500 responses, and what they found is that understanding varied dramatically between the groups. So 89% understood the labels with specific times, 77% understood time periods like morning versus evening, 61% understood times like twice daily, but only 59% understood those hourly intervals like every 12 hours. So basically what this looked at identified that literacy was included as a data point and identified that patients with low literacy were significantly more likely to misunderstand. Overall, this demonstrates that medication labeling can be misunderstood, and of course, there's no one size fits all in this approach.
Oh, that's exactly right. The more complicated the label is, the more likely someone is to get it wrong. Labels get confusing when there are several directions piled together, when they're written at a high reading level, when the medical jargon sneaks in, or when icons don't match the text. And those tiny warning stickers, people either can't see them, can't interpret them, or honestly, they just ignore them. And even though the Davis study showed that people understood specific clock times pretty well, real life can get in the way. For example, if someone works the night shift and their label says take at 6 a.m., 2 p.m., and 10 p.m., that may not match their schedule at all. So labeling with specific times like in the morning or after breakfast may actually be clearer. So the key is matching the instructions to the person's life. Because it doesn't fit their routine, it won't stick. Ultimately, we want to be as patient-specific as possible.
Yeah, I can see how complex instructions really could lead to what we would call medication non-adherence, but may not really be that at all. Sarah, can you talk a little bit more about that, about medication adherence and potential for non-adherence if directions get mixed up and how this can be addressed?
Yes. Thank you for asking, because this, of course, is a vital topic for all patients and providers. When we think about medication adherence, it's multifaceted and ultimately should be addressed in a patient-specific manner. I really like the World Health Organization document that talks about adherence because it identifies 5 key areas of medication non-adherence. The 5 areas include health system related, patient related, condition related, therapy related, and socioeconomic factors. I find that this is really helpful because understanding the underlying cause of non-adherence is really important to identifying the appropriate solution. There can be many potential solutions for improving adherence, but obviously these need to be tailored to the individual barriers. So for example, if a patient can't afford a medication device, offering education on how to better use the device probably won't improve their adherence. Alternatively, if a patient is prescribed a really complex regimen with many dosing times, education and accurate labeling may be the best approach to improving adherence for that patient.
Yeah, that makes a lot of sense. So, Karen, from a nursing perspective, you have many years of experience administering medication to patients in the hospital and in other settings. Can you share why medication labeling matters and why patients might struggle?
Sure. So in nursing, we all learn the basics of how to administer medications, but this often doesn't cover labeling and ordering prescriptions. We're taught the 6 R's of medication administration: the right patient, right medication, right indication, right dose, right time, right route. But most patients and families have never been taught that framework. Many people skim labels quickly or follow a routine based on what they thought the instructions meant weeks ago. And honestly, errors can happen on both sides, providers and patients. Often the real issue is that somewhere in the chain, the communication wasn't clear enough. Things like look-alike labels, tiny print, Long instructions, name confusion, or complicated dosing can make it really hard for patients to take the right medication for the right problem at the right time for the right amount of time in the right dose.
Yeah, really, really great points. So I want to talk a little bit more about labeling. It's come up a couple of times. So, Sarah, as a pharmacist, can you give us some common examples of medication errors caused by labeling?
Sure. There can certainly be many examples. And again, these vary based on the specific patient and their circumstances. But one specific situation that comes to mind when a prescription states take 1 tablet twice daily, patients may interpret this as 2 tablets in the morning, or 1 tablet in the morning and another a few hours later, or even 1 tablet every 12 hours. And of course, depending on the medication, the ideal frequency may differ. Another common issue that I see a lot is missing timing information. So if the label doesn't say when to take the medication, for example, in the morning or in the evening, adherence can be impacted. This can be really concerning, for example, with medications like once daily basal insulin. Patients may take this once a day, but there can be glucose implications if they take it in the morning one day, but the evening the next day.
Sure. I can see how that's concerning. One issue that comes up often in my practice is when patients are unsure how to take medications surrounding meals.
Yes, I see this all the time as well. Patients focus way too heavily on this and often miss doses if they miss meals or they have variations in their diet. And of course, this can be a problem based on how we describe taking it with their food. So some examples with food to some patients could mean with a full meal or just a snack. We would want to say take with a meal or a snack to be more inclusive. If we say before meals, patients may apply that to immediately before, 15 minutes before, an hour before. This is also unclear. So ideally, we would want to say, take 1 tablet in the morning, 30 minutes before breakfast, or 30 minutes before dinner, depending on the medication. And then the final one surrounding food is an empty stomach. And this can also be unclear. So when is our stomach empty, before or after eating? How long is that time range? So saying, take 1 hour before eating or 2 hours after eating might be more specific than empty. When it comes to chronic conditions like cardiovascular disease or diabetes, errors can become even more complex related to multiple medications and the chronicity of their problems. So I like to recommend patients use certain tools available to help them with this. So these could be reminder aids, pill organizers, or even adherence packaging at the pharmacy. Again, we want to be as patient-specific as possible because no one size fits all, and we want to use those universal precautions when it comes to literacy and labeling. So if instructing a patient to use a medication twice daily, we should talk with the patient so that we can understand their lifestyle and provide specific examples or educations at that point of care.
Oh, I completely agree. Another tool to ensure adequate understanding when using these patient-specific approaches is the teach-back method. Using the teach-back method can ensure patient understands the instructions provided, but we can take it a step further and use Teach-Back 2.0, which is about inviting the patient to walk us through their actual plan, when they'll take it, what they'll take it with, and what might get in the way. It opens the door to problem solving together.
Yeah, that's a great reminder that Teachback is a really useful tool here. And luckily for our listeners, we have a great podcast on the Teachback method, so we can make sure to link that in the show notes. All right. So, Karen, one more question for you. What are the biggest factors, do you think, that are playing into patients making the medication errors?
Well, medication mistakes are incredibly common, truly, to people of all backgrounds and education levels. But for someone with vision challenges, low reading or math skills, cognitive issues, or stress, those mistakes are even more likely. Because we can't know who's struggling, we should assume that everyone could benefit from clearer communication. That means simplifying and standardizing labels and using Teach-Back consistently. It's really about creating systems that work for all patients.
Yeah, really, really helpful. And Karen, I believe you have an example for us today about how a missed opportunity for the teach back method impacted a patient's life. Would you be okay sharing that with us?
Oh, absolutely. Yeah, this is a personal story related to my mother in law. She underwent open heart surgery. Oh, I think she was 75 years old at the time and did well after surgery, with the exception of developing atrial fibrillation, for which she was placed on warfarin. At her 6-month checkup, her doctor said, "Well, Nancy, you're doing great, but I'm going to start you on a little aspirin." He then went on to explain how aspirin has similar blood thinning qualities as warfarin. Well, my mother in law went home, started the aspirin, and stopped warfarin, which of course was not his intent. Well, my husband and I got a call within a week saying we needed to get to Pittsburgh right away because Nancy was admitted to the intensive care unit, placed on a ventilator because she had multiple pulmonary emboli.
Mm.
So we just have to stop and think for a moment. If teachback had been incorporated in her visit, we have to wonder if that near fatal event would have even occurred.
Yeah. Yeah, really impactful. And I certainly understand how that really reinforces how important this is in patients' lives. How's she doing now?
Oh, she's doing great now, back to her old feisty self.
Glad to hear that. All right. So going back to Sarah for a little bit. So, Sarah, can you tell us from a pharmacy standpoint what guidelines or recommendations are out there to help address this problem, to help improve prescription labeling and clarity for our patients?
Well, the U.S. Pharmacopoeia, or USP, has some clear guidelines that can help. So first, we want to feature only the most important information on our labels. The labels should include both the brand and generic names. We want to include the purpose for use when possible. We want to make sure that we're using at least 12-point font for all critical information. We want to avoid all caps and use simple fonts like Arial or Times. And then we want to use black ink on a white label with our text in a horizontal way. Additionally, when we lay out the label, it's important to place the critical information at the top and the less critical information, like the pharmacy name, at the bottom of the label. And then again, with those dosing instructions, like we have given other examples, we want to be as explicit as possible. So saying morning and evening versus twice daily, or whatever you've identified with your patient in those discussions that best fits their lifestyle.
Absolutely, Sarah. And I would just like to add that there are best practice guidelines for auxiliary labels as well. Research has shown that patients often miss or misunderstand them, especially when they're printed in tiny font or stuck vertically on the side of the bottle. So the recommendation now is to use them sparingly, keep the wording simple, and pair them with clear icons that have been tested with patients. They should be placed horizontally where people can't miss them when possible.
Yeah, really interesting. One question I've been thinking about, what about patients with language barriers? So, specifically for those with limited English proficiency. I heard a story about a Spanish speaking patient who accidentally overdosed on his blood pressure medication. He wasn't able to read the English on the label, and he read once daily as once, which is Spanish for 11, and came in with critically low blood pressure as a result of having taken 11 blood pressure pills at one time. So, what could have been done either from the provider or pharmacy standpoint to help avoid that situation for him?
Wow, that example is really impactful and obviously highlights the importance of ensuring we have appropriate labeling for patients as well. The good news is that many of our pharmacies can translate directions into other languages. So this is where that interprofessional collaboration is key. So in working with a pharmacy in your area, make sure to find one that can provide labels in another language and make sure that you mention this to the pharmacy. Patient instructions and after-visit summaries can also be printed in the patient's preferred language from many electronic health records and pharmacies as well. Also, in the setting of needing adaptive labels, so those with tactile ink or talking labels for patients with low sight are available at some pharmacies as well. So ultimately, we'd encourage providers to make sure that they are sending the prescriptions to pharmacies that can do this and then communicating with the pharmacies if these things are needed to make sure the patient gets the right label.
Yeah, that makes a lot of sense. So another question on that, what's legally required to be on a prescription label and who determines these requirements?
Each state actually has their own requirements for prescription drug labeling. Many states, of course, are similar, but in Ohio, pharmacies are required to include the pharmacy information, including the name and contact information, the patient's full name, the prescriber's information, directions for use, the date the medication was dispensed, cautions and warnings required by state or federal law for the medication, the prescription number, and then, of course, the drug information. So this would be the name, the quantity, and the strength.
Okay. Do we know what patients want on their labels? What information is actually helpful to the person taking the medication?
Well, according to a survey conducted by Wisconsin Health Literacy during its multi-phase medication label initiative, patients are really clear about what they want. They prefer labels that prioritize the most critical information, especially drug name, purpose, and prescriber's name, clearly placed at the top with larger font and white space. Patients also prefer warning labels with simple, plain text plus meaningful icons. So using simple, consistent language is essential. We must meet people where they are, whether that's differences in literacy, language, culture, vision, hearing, or even stress they're under in a healthcare setting. So clear communication isn't about dumbing it down. It's about removing barriers so that everyone, regardless of background or circumstance, can use their medications safely and confidently.
Yeah, I see. It's not just the pharmacy's job to make it clear. So as a prescriber, I can ensure I'm writing appropriate instructions as well as working with my IT department to ensure our electronic medical record can support literacy. So, Karen, can you talk a little bit more about some of these electronic medical record, these EMR tools that are being developed that can be utilized to help improve understanding?
Absolutely. Our electronic medical records can help a lot, and several things can improve label readability and patient understanding. For example, using ramp, taper, or split dose functions when ordering medications that taper up or down.
Oh, those sound useful. Can you explain those functions for our listeners?
Sure, ramp and taper functions in the EMR are really helpful. They let providers gradually increase or decrease a medication dose over a set period of time. So they're used a lot when starting a new med so the body can adjust slowly and safely. These functions spell out the dosing changes clearly, which reduces confusion. Another great tool is using templates for commonly used prescribed medications. And we can also increase the character limits in the instruction section so nothing important gets cut off. And when the instructions are longer than what the label can hold, pharmacies can print supplemental directions. We just need to make sure we take a moment to walk patients through those extra pages so they actually make sense. And associating diagnoses with medications helps patients understand what each one is for, which improves adherence.
Yeah, thank you. Before we go, are there any closing thoughts?
Yes. Ensuring patients understand how to safely and consistently use their medications is vital to improving health outcomes. This encompasses addressing medication adherence, providing patient-centered education, and ensuring labels are easily understood. I want to highlight a few things prescribers can do at the point of care to aid in this process. So first, they can use medication reconciliation regularly to address discrepancies. A lot of times in my clinic, patients assume that the list in the office is 100% accurate and don't realize that sometimes these things can be inaccurate when patients go to multiple providers or maybe are in and out of the hospital. So really addressing that at every visit is key. We want to advocate for system-level solutions in the electronic medical record to help standardize ordering and labeling throughout. Providers can also recognize that staff have a role in patient education and are great for using the teach-back method as well. And we want to advocate for enough time with patients and appropriate support on the patient care team to ensure that medication education is completed at every visit. Additionally, pharmacies can support this as well. So pharmacies can ensure that they have readable labels and that the clarity of labels is improved. We can also use medication therapy management, or MTM, to address discrepancies at the pharmacy as well. So if we're completing, medication reviews in the office and in the pharmacy, hopefully we're catching any discrepancies and educating the patient appropriately. And then finally, we can all work to use plain language and the teach-back method whenever possible.
Yeah, I'd just like to add, overall, besides ensuring labeling is clear, it's the role of all healthcare members to ensure patient understanding. And as we've mentioned, tools available include patient education, warm handoffs between providers, motivational interviewing, and as Sarah just mentioned, teach-back or teach-back 2.0.
Yeah, this conversation is so important, and we hope it empowers more healthcare professionals to think critically about labeling and communicating more clearly with patients. So if you, our listeners, have other specific situations that we did not address today, the United States Pharmacopoeia, Chapter 17, offers additional recommendations and guidance, which we will link for you in the show notes. Thank you so much to our guests for sharing your expertise today. And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.